Presenting a new series, Medically Verbal, where we'll solve case history in just a couple of minutes. Disclaimer: these case studies are for understanding purposes. Inaccuracies may be present. Do not attempt these processes without the guidance of a licensed medical professional. Case 19. Chief complaint. A 40-year-old male presents to the clinic with gradual progressive dyspnea on exertion. History of present illness. The patient reports feeling increasingly short of breath over the past 6 months, especially with physical activity. He denies chest pain, palpitations, cough, or wheezing. He has also noticed swelling in his ankles towards the end of the day. Past medical history: hypertension, type 2 diabetes mellitus. He is currently on metformin for diabetes and lisinopril for hypertension. He occasionally consumes alcohol and is not a smoker. His father had coronary artery disease. Physical examination shows BP 140 systolic, 90 diastolic, heart rate 82, respiratory rate 18, temperature 37. Respiratory region is clear to auscultation bilaterally. Cardiovascular region showing regular rate and rhythm with no murmurs. Extremities show +1 grade of pitting edema in bilateral ankles. +1 is basically a mild form where the pit is 2 mm deep. There are 4 grades, +1 to +4, and this type of gradation goes away in some seconds. Initial differential diagnosis: chronic obstructive pulmonary disease, heart failure, pulmonary embolism, anemia, obesity, hypoventilation syndrome. Based on this presentation, what do you consider the most likely diagnosis and what further investigations or management steps would you recommend? We all know that in COPD there is obstruction from a very long time in the pulmonary airways. In case of heart failure, the heart fails to pump enough blood to circulate, which eventually leads to its own death. In case of pulmonary embolism, a clot is circulating in the whole pulmonary circulation area. In case of anemia, there is decreased amount of RBCs and hemoglobin. Obesity hypoventilation syndrome is just what the name sounds. People who are very obese have difficulty in taking deep breaths or taking short breaths, because of which their body is not able to meet the required oxygen supply. If you are thinking heart failure, then you are on the right track. We're ruling out COPD or pulmonary embolism because there is no cough, there is no wheezing. So COPD to happen is very less likely. Steps would be to perform diagnostic investigations by performing an echocardiogram, which is done for the structure and function of heart, so that we could see whether there is a reduced ejection fraction or any sort of diastolic dysfunction. We perform a chest X-ray to see for pulmonary congestion and cardiomegaly, just to be sure. We'll check out the troponin levels to eliminate myocardial infarction. We'll check the blood glucose level because the person is diabetic. So to assess for diabetes or impaired glucose tolerance, we'll check for B-type natriuretic peptide. Of course, that would be elevated in case of heart failure. For management, we would administer him on ACE inhibitors or beta blockers, diuretics, and aldosterone antagonistic according to the echocardiogram findings. We'll ask them for lifestyle modifications, ask them to take less of salt and exercise. We'll ask them to regularly follow up and monitor symptoms. Then accordingly, we'll optimize the medication therapy and assess the response to the treatment. Corrections or suggestions, comment down below. Make sure to like, share, subscribe, and hit the bell icon to never miss another update.